Well, hello there, everyone. Thank you for joining us for our June Craig Rehab U webinar series. I think we still have a couple people hopping on. So I did want to go over a little bit of housekeeping, if you will. My name is Tracy Jensen with Craig Hospital's Provider Relations team, and I'll be your moderator today. A little bit of housekeeping, as I mentioned, for continuing education credits. There will be 3 poll questions that'll be launched throughout the webinar. Please be sure to answer all of the questions to receive credit. In all honesty, you have to answer at least 2 of the 3. You must attend at least 50 minutes of the presentation to receive credit as well. You do need to make sure that you are signed on with the email that you use to register for the presentation. And if you're in a room with multiple people, each person will need to sign on individually to receive credit. I do have an affidavit if there is a group of people. You can reach out to me at tjensen@craighospital.org if you need to have that group one sent to you. And credit is being provided by our partners at CEU Institute. So you'll be receiving an email directly from them after the webinar regarding any credits and any additional information they might need from you regarding your license requirements. With us today, I have 2 of Craig Hospital's amazing occupational therapists, Karen Rasavage and Amy Berryman. They'll be providing our presentation on vision impairments in ABI rehab. A little bit about both Karen and Amy. Interestingly enough, they both graduated from the University of Oklahoma and have both been an integral part of the ABI continuum of care. Karen works as an interdisciplinary education coordinator and vision clinic coordinator at Craig Hospital, and she specializes in collaborating with neuro-optometrists and places emphasis on integrating occupational therapy concepts such as sensory integration and activity analysis, individual rehab with children and adults following a brain injury. Karen and Amy have both been published in the areas of interdisciplinary rehabilitation, vocational rehab, and vision. Amy has also worked through the continuum of care and vocational rehab, and she has additional training in NDT techniques, serial casting, and other modalities to facilitate neuromuscular recovery. Amy completed, I actually am reading from that, from the University of Oklahoma as well, and graduated with her master's degree in health services administration from Regis University. She's an adjunct professor for the Creighton University Occupational Therapy Program, facilitating the neurorehabilitation lab coursework for their Colorado cohort. If you have any questions during the webinar, please feel free to submit a question in the chat or message window, and I will ask your question either during or at the end of the presentation. Without further ado, I would love to hand things over to Karen and Amy. Welcome.
Thank you, guys.
Hi, everyone. We are really glad to be with you today to talk about one of our favorite subjects, which is vision rehabilitation and addressing vision problems during the rehabilitation process after an acquired brain injury. Karen and I have been working together now for 22 years. We started OT when we were babies, and we were very lucky early in our career to get good mentorship and examples of how it is possible to address and take care of patients well with vision problems after their injuries. So we're excited to share some of what we know with you today. And what we would like to cover in the next hour is reviewing basic vision anatomy, just to lay the foundation. We want to talk about the common acquired brain injury related vision impairments, what you might see. We want to talk about the benefits of early intervention to help patients better participate in rehabilitation. And then we're going to talk with you about what we think are some helpful vision related remedial and compensatory interventions that may be useful to you in your practice or what you do. So just to start, vision is our farthest reaching sense. It goes beyond what any of our other senses can do. Between 70% and 80% of how we learn and interact with our environment is in at least a part mediated by vision. Vision guides us through space. It allows us to reach outside of ourselves. It guides motor movement, so it's not just an input process. It also, the visual process involves input and output, and it helps us, it gives us information to help think, plan, and respond to the world. And there are several studies that estimate that between 50 and 90%, all the way up to 90% of people with brain injury have at least some sort of visual impairment. And visual functions, as you'll see moving forward, are represented in every lobe of the brain. So we're going to start with just a little bit of vision anatomy. First thing we want to talk about is just the eye itself. The eye is allows us to bring information in, and it has a few structures that I think are important. The cornea is the covering of the eye. It protects the iris and the lens, and it really is the barrier that kind of keeps the eye healthy. And it can get injured or dry or hurt in an injury. The retina is what allows, it's basically the extension of the optic nerve that allows information to go into the optic nerve, which is the first cranial nerve that brings information in. And then the lens is what allows us to keep things in focus. And interestingly, after an injury, a person's been at rest for a while, not doing their normal level of activity, the lens can change and actually cause a change in visual acuity. And then there are 6 muscles of the eye that are involved in moving the eye around to gather information from the environment. The superior rectus and inferior rectus allow for up and down. The medial and lateral rectus allow for side to side. And the superior and inferior oblique muscles allow for diagonal movements and even a little bit of torsional rotation of the eye. Here you see a picture of the optic, basically the optic pathway from the eye down through the optic nerves. The optic nerves intersect each other and crisscross at the optic chiasm, and then you see nerve fibers that go all the way to the back of the brain in the optic nerve, or in the occipital lobe, which is largely responsible for our perception of vision. And usually is the one area of the brain that's attributed to vision. But as you're seeing, there's functions of vision throughout the brain. Here is a visualization of 2 visual pathways, the dorsal visual pathway and the ventral visual pathway. These 2 are really important for rehabilitation because they answer 2 primary questions for our safety and survival. The dorsal visual pathway goes through the parietal lobe and is involved, helps with our spatial processing. So it answers the question for us, where am I? So the dorsal visual pathway helps us understand location, movement, spatial transformations, how we relate to other objects in the world, and really is responsible for keeping us upright and moving safely. The pathway that goes through the temporal lobe is largely involved with object processing, or what is it? So it's the more detailed processing of what is the texture of what I'm seeing, what's the detail, what exactly is this object that I'm looking at. So these 2 processes work together to help us understand where is the object that I'm supposed to be looking at, and then when I look at it, what is it? And we think about this a lot in rehabilitation, actually, when we are working on mobility and moving people around. It's not usually our patients, if they can't see things clearly or identify objects, but they're doing okay with their wear processing, they're usually pretty safe navigating through the environment. But when people have their dorsal stream, when that gets impaired, it really makes it hard for them to be safe. And then here is a picture of the brainstem, and this is where most of the cranial nerves originate. Being at the base of the brain, it's susceptible to injury, especially during coup contra coup type lesions, where there's shearing involved and the brain is kind of moving along the brainstem. The nuclei of all of those cranial nerves are back here. So when people get a midbrain injury, we often see people not being able to move their eyes well. They may or may not be able to close their eye or eyes. They can also, with an optic nerve injury, we'll talk about this a little bit more, not be able to see at all out of one of their eyes. But most important, I think, for takeaway, besides seeing how vision is represented throughout the brain, is visual processing itself. It is a sensory motor process that allows us to be, that helps us be functional in the world. So the afferent information is what comes in. So our eyes help bring information in, and that involves using our eye muscles to move around and scan and gather information. Then there's an aspect of processing that happens in the cortex, and then there is an efferent or motor response, which means the eyes move to where they need to look. The body moves in order to be where things need to happen in order to look and see. And so just really thinking about vision, not just as seeing clearly, is important in rehabilitation, because it is a whole process that involves both input and output of a person. So now we're at our first poll question, and I'll have Tracy offer you the poll.
Great, so I will launch the poll. We'll give you about a minute to answer, or I can see how many people have answered. So everybody's speedy, Amy. They're already at 70%, so might not even need a whole minute.
It was a really tough question.
These true and false ones can be tricky, though. You never know. We're almost at 90%. So. Okay. I think we're up pretty good.
Okay.
We're at a minute, so I will go ahead and close that out and let you guys continue on.
Okay, thank you. The answer to this question is false. Visual function is not represented only in the occipital cortex. There's a function of vision in every lobe of the brain. And now let's move on and talk about just some common injury-related visual impairments. From an acquired brain injury, a person can have changes in their visual acuity, which is clarity of vision. They can have changes in their fixations, and so that's their ability to hold their eyes still on an object and perceive that the world is holding still. We see this most frequently with nystagmus, which is an instability of eye movements where there's a slow and quick phase of movement that can often make people feel dizzy or just have difficulty reading or doing activities that require a steady focus. People can have impaired pursuits, which is the smooth, coordinated eye movements that allow us to track objects as they move across our gaze. You can see impairments in Cycads, which are quick back and forth movements that allow us to shift gaze. People can have impaired gaze stabilization, which means their eyes might be able to stay still, so they can fixate and hold their eyes still, but when their head starts to move, they they lose their focus and feel like they're also moving. This is a big cause of dizziness after an injury and motion hypersensitivity, and it is a function that interacts with the vestibular system very closely. Cranial nerve 3, 4, and 6 can get impaired. Those are our eye movement or eye muscle cranial nerves, and so that can cause an eye to shift its position and not be aligned with the other eye. Cranial nerve 5 can become impaired, and that affects the ability to close the eye, and that is a major eye health issue when a person can't blink, because their cornea gets very dry and then can get scratched. And when a person gets severe enough scratches on their eye, they end up getting blindness, and they can't see anymore out of that eye. It's like looking through scratchy wax paper, and end up, if possible, need to have that, that may never heal, or they would have to have a corneal transplant to get that better. Cranial nerve 1 can be impaired. The optic nerve can be impaired, and that affects sight in general. A person will then have blindness in one or both eyes. You can have a visual field cut, which means the scope of vision is gone, and that can happen equal in each eye. So, for example, the left half of each eye can't see or is gone, or the right half, but you can also have superior field cuts or inferior. Or you can have, in general, if you have occipital lobe damage, you can have cortical visual impairment, which is what we kind of consider like a, I don't really love the term Swiss cheese, but kind of a patchy field loss where, it's not in a specific pattern. And then perceptually, you can get what's called unilateral visual inattention, or where a person just can't attend to one side of space. And then with eye health issues, those can happen from an injury, or just from being in bed, or not blinking very often, or shedding dry skin, which is kind of interesting. So some of the eye health issues that do frequently come up are dry eye. People who have a brain injury typically also have a lower blink rate. And here in Colorado, almost all of our clients with brain injury have dry eye because it's just dry here, combined with not blinking as often as possible. Patients can also get blepharitis, which is eyelid inflammation. I think that often comes from, having drier skin, and getting skin buildup around the eyelid, and it's a very uncomfortable, painful inflammation. Same with keratitis, which is a corneal inflammation. Patients can also get papilloedema, and that's from swelling of the optic nerve. That can be caused from intracranial pressure or changes in blood pressure, and we see this often in not just our brain injury patients, but also sometimes with our spinal cord patients from their ICU stay from laying flat and paying attention to so many other life-saving measures that, there's been a long-term pressure issue behind the eye, and that decreases. It makes patients' vision very dim and reduces the quality and clarity of their vision that can't be fixed by eyeglasses. People also can have what's called Tersen Syndrome, which is a hemorrhage that goes in the vitreous of the eye. So in front of the retina, in the gelatinous area of the eye, when you get blood in there, it clots, and then it becomes opaque, where you can't see through it. And then a person seems blind in that eye, but what they really have is dried blood behind there. And it's very easy to diagnose in terms of when you're looking in the eye, you don't see a person's red reflex with a light. And it's a very simple surgery to remove the hemorrhage, and often can restore vision fully in a person's eye who has this particular syndrome. We already talked about corneal abrasion, and then patients can also have orbital fractures from their injuries, and sometimes that causes swelling, which then can make eyes misalign, or a patient can have double vision, or some of the, like the part of an eye muscle or tendon can get entrapped inside of a fracture, making it difficult to move their eyes in all directions. So when people have both these eye health issues and the visual issues that we talked about, it greatly impacts their function. And when patients are in rehabilitation, our main goal is to help them maximize their function. And you know, when they have vision issues, they may be experiencing blurry vision, double vision. We see often blindness in one or both eyes. We just talked about all of the eye health issues. This can make patients very tired. It takes a lot of energy to try to see and think with your eyes when they aren't moving well, or they're having double vision, or part of their visual field is gone. We see people being imbalanced. Their reading ability is decreased. They have a harder time paying attention. They're missing objects in their visual fields, so their dorsal visual pathway is impaired, which makes it harder for them to move through the environment safely. They might have poor attention and poor scanning. And then here's just a little chart that talks about what problem could be happening. And pardon our more medical terminology in this chart. We just think this is a helpful one for you to have, to just as a reference sheet of what could be happening, and also to show that that one behavior doesn't always mean just one deficit. So it's not like blurred vision is only caused by acuity issues. It can also be caused by eye movement problems. It can be with alignment issues. This is just a good example of why it's important for us to really evaluate patients with a visual complaint to see what the root cause is in terms of their injury. So we think that inpatient rehabilitation is an ideal setting for initial evaluation and treatment of visual issues, because the results of the evaluation can help us improve their participation in rehab, and can help make good recommendations for when they get out of rehab. And at the very least, getting a basic visual screening is something that can happen you know, as a part of their rehab evaluations, and we can really just help, I think, set the path out and see what's happening for a person and help them get better practice while they're in rehabilitation. But we do also think if a person has eye health issues, we think those should be screened for at every level of care, starting at the ICU. So if a person doesn't have their eye closed, or they aren't able to, then we need to do compensatory type interventions to help keep them healthy, so that when they do start functioning better, they won't have contracted a long-term health issue.
Amy?
Yes?
Sorry. Question for you. When should, like, how early within an injury or after an injury should someone be evaluated?
I think, you know, when a person's in the ICU, they're not necessarily responding well, but you can look at things like when their eyes are open, are they aligned? You know, do they appear red? Are their pupils responding? You know, so I think even in the initial ICU stay, once rehab gets called in for their initial evaluations, I think vision needs to be on the docket in terms of just getting it on the radar. And if there's an eye health issue, then there could be a consultation with whoever is the rehab consultant, you know, whether it's an ophthalmologist at the hospital or an optometrist or whoever they use as their consultant. I think that can be helpful just to keep tabs on what may end up being a longer term issue. But once a person hits inpatient rehabilitation, for sure they can participate on some level in a visual screening. And then come back to inpatient rehabilitation, we do know that neuroplasticity is possible and it requires good quality of practice. So if a person needs glasses that were broken in the accident and they can't read anything because they don't have their glasses, how will they participate in the reading activities that they need to do for their speech therapy, or, being able to scan the environment well? And then, their learning then is going to be delayed, because there's a big piece of input that isn't happening for them. And again, because vision is an input and output process, it's really helpful when we can maximize their visual function to help them participate better. So when we talk about vision evaluation, there are 3 parts to that. There would be a vision screening to identify any issues. You don't have to just call the eye doctor on all patients. You have a rehab team who can do a vision screening, and if needed, can recommend an eye doctor consultation, and then together developing a treatment plan based on that evaluation. We think every inpatient should get a screening for referral. And for some of you who are out there who maybe haven't been doing vision screens, I would recommend you doing a 3-month challenge. 3 to 6 month challenge where you decide OT or PT or another discipline doing a screening on all the patients and collect them in a book, and then look back at the end of those 3 months and see if you can tally what issues you're seeing with your patients, like what's most frequent, and that may help you decide as a team some things that you can do to help improve how you address this for them. And we don't recommend any one specific screening, but we do think a screening should have these parts to them. So there should always be a visual history, an eye health section. So does a person have a significant history, like they were blind in one eye before they had their accident, or did they have an eye surgery recently? Have they had LASIK? We recommend that you look at eye movements, so fixations, pursuits, saccades, and gaze stabilization. We recommend eye alignment. So do the eyes point in the same direction together, and then can they team together to keep things in focus? And then we recommend looking at visual fields and visual attention. This is a picture of the screening that we use at Craig. As you see, all of those parts are there. And at the very bottom, we have a section that says therapist comments and observations. So this has to do with some of their behavior or posture or things that we're noticing or other questions that we have. And then we have an assessment plan, which usually says to refer or not to refer, and what we're thinking about doing with the patient. So if you're wondering what would be good to refer for, we worry about any acuity that is 20/40 or less, unless it's really, really bothering the patient. Most patients can get by, and most of us in the world can get by with 20/40 or better. But if it's 20/40 or less, that will be impacting their reading or their ability to see things clearly, which will then be impacting negatively their processing. If a person has nystagmus, that would be worth an evaluation if their range of motion is limited in any way, or if they have an eye turn, that is good to get evaluated. If they're having double vision, photophobia, field loss is good to get confirmed in an evaluation. And then if they have questionable eye health, any eye health issue, we would recommend getting a evaluation. And then people always ask, at Craig, we have a rehab team, and we're going to talk about that a little bit when it comes to vision. We primarily use an optometrist as our first line of evaluation. So optometrists are allied healthcare professionals that perform primary vision care. They can handle eye health issues. They can recommend glasses and contacts. Often there are a certain subset of optometrists that focus on vision therapy and low vision services. And also there are ones that focus on rehabilitation and interventions that help support a rehabilitation process for patients. And we find that this is good for triage because they can come in and do these things and then recommend if there's anything out of their scope that needs to happen. But also an ophthalmologist can be helpful too, because they can also prescribe glasses and contacts. They can do even more in-depth eye disease management, and they have a medical degree. So if there's anything that would require a surgery or something more medically intense, an ophthalmologist is helpful. And so we have at Craig an eye doctor, but we also have a retinal specialist that we recommend or that we refer to. That person helps us primarily when we see a person with Tersen Syndrome or vitreous hemorrhage that needs a surgery. We also collaborate with neuro-ophthalmologists for more medical needs. We collaborate with an oculoplastic surgeon and a cornea specialist, and we have ocular surgeons that we work with for longer term outpatients who may need or want an eye alignment surgery, if they have long-term eye misalignment after their injury. But that wouldn't happen for many of our patients until they're far, far into their healing.
Amy?
Yes.
Do you mind if I pop in? Wondering if you could expand a little bit there. We had a question as far as expanding a little bit more on what photophobia is.
Oh, thank you for asking. I'm sorry I didn't clarify that. Photophobia is light sensitivity, light hypersensitivity. And functionally, that makes people very uncomfortable under fluorescent and bright lights. And guess what most hospitals have? Fluorescent lights. So that is a very common impairment that we see in people with brain injury. And we work hard to try to help them with that.
Definitely. And do you have any recommendations or interventions that someone may be able to be, that would be appropriate in an ICU setting? We do have several folks that are, in that ICU setting, if there are some things that they could keep an eye out for or try to address in that setting.
Yes. Stay tuned. Coming in the next 5 minutes. Yes, we do. We're going to talk about that.
Okay, and one more quick one.
Sure.
The difference between a neuro-optometrist and ophthalmologist.
A neuro-optometrist does not have an MD degree. They have 4 years of school, so they are considered a doctor, but not a MD. They didn't go to medical school. And I kind of separated in my mind of like an optometrist being a allied health professional, like PTs, OTs, who has specific schooling in vision.
Gotcha. Great, thank you. More to come.
Yeah. So when working with an eye doctor, and this is a picture of Dr. Politzer, who is one of Karen and I's long-term collaborators. We've been going around the country helping teach rehab centers about how to help people with vision problems in rehab. We've been doing that together for probably 20 years, and we think over our time we've helped educate over 1,200 people or more. Just get more comfortable with this type of intervention. But the main thing that we like to model when we go out and teach is collaboration. When we start to be extra protective of our turf, I think we lose out in terms of really being able to use our expertise in a way that can be helpful to people. So having a collaborative relationship really helps patients get better, and it helps put more minds on the scene in terms of getting people better. So we recommend when working with an eye care consultant, whether it's an optometrist or ophthalmologist, that a rehab center or a rehab professional have some sort of vision screening method. So we're the ones that are taking a screening to see if there needs to be a referral. Then there needs to be a mode of consultation. Maybe the eye doctor comes in and sees them, rounds in the hospital. Maybe the patient goes out to their office. If it's an outpatient, maybe they just go to their office. Sometimes there could be a therapist involved or not, but there needs to be a way of consulting with that doctor, and then a collaborative treatment planning. So there needs to be follow-up back from that doctor of, here's my findings, let's talk about your findings and what can we do collectively to help the patient be better. And what an eye doctor can offer to a rehab team is prescription of lenses, prisms, eye health, and really getting in and giving the thorough evaluation and diagnosis of what's happening with their eyes. As a rehab team, we can't prescribe lenses, we can't give contacts, we can't, give medicine or prescribe medicine for their eye health issues. But also having that collaborative treatment planning with lenses can really help up a person's quality of practice while they're in rehabilitation. And then there needs to be some method for follow-up where the patient can see that eye doctor again if needed and get their glasses adjusted or whatnot. So Karen's going to tell us a little bit about how our clinic at Craig goes.
I'm still swirling on that last picture and what babies we were at that time, and how we had Dr. Pulitzer for several years since we started. I think 18 years ago when I started at Craig, he was there, and he has since retired and moved on to greener pastures of Grand Junction to ride his bike and have a good time. So he had a colleague purchase his practice and move into working with patients with neurological injuries, and her name is Dr. Carrie Jarvis. And she has been coming into our Craig Vision Clinic, which happens once a week. And she comes in for about 4 or 5 hours, depending on the scheduled clinic times, and sees inpatients and outpatients for either initial appointments, and those are 30 minutes long, or follow-up appointments, and those are 15 minutes long. There is always a vision clinic leader, myself, or 3 other OTs who are trained as leaders. And we help to work on the scheduling and making sure that patients and their therapists have the information to come into clinic, and we are communicating with the doctor. Dr. Jarvis is credentialed at Craig, and she does her own documentation and her own billing through her practice. Documentation is shared very quickly through our Epic documentation system, and she quickly communicates with doctors when there is any need for orders or medications. And so there's a very good back and forth communication that occurs. The primary OT also comes to this appointment with their patient so that we can have a collaborative conversation about, once we get the diagnosis, treatment options, how we can work together as a team. Sometimes the PTs and speech therapists come in from the team because they want to know how this is influencing their speech sessions or their gait training. So it's a really great opportunity to have interdisciplinary collaboration on vision rehab. So poll question number 2, we'll let Tracy take this away.
You bet. I'll go ahead and launch that now. We'll give you about a minute for what some common visual impairments could include. While we're waiting for folks to answer, I think I had another question. There was a question about can a TBI cause a detached retina? If so, is that something that would manifest itself soon after the injury, or is it possible it could come up years after?
Yes and yes.
Mm-hmm.
Yes and yes. Yes, that's something that when yeah, as a part of what an eye doctor can help check out. And the signs for a detached retina would be seeing flashers and floaters. So that's something that we always, kind of pay attention to. If a patient is saying that they're seeing flashes and floaters, we want to get them an evaluation right away so that if the retina is detaching, that it doesn't get all the way detached. And that requires a surgery with some laying flat to get better.
Mm-hmm.
Great. And then we had one other quick question. Do you use any specific tools objectively to objectively screen for diplopia?
The tools that we use for screening, we use just on our visual screening. We do in our clinic, we do a Hirschberg test, which is just a very, very rough initial screen to see if light is reflecting equally in each eye. But then we do a cover on cover test, an alternate cover test to screen. But with Dr. Jarvis, we will use Maddox rod testing to determine how wide of a misalignment there is. Mm-hmm. And then if patients, so a lot of our outpatients will sometimes see Dr. Jarvis in her office because she has more machines there that can do more precise testing, but we find that with her, what she can bring in her little rolling suitcase can usually get us going enough to help a patient improve and get them on a really positive recovery curve.
Great.
And before even any of the, oh, I'm sorry.
Oh, sorry, Karen, I was just going to close out the poll.
Okay. Nope, I was just going to mention that before even the objective double vision screening pieces, your subjective pieces are coming into play throughout all of the disciplines. Someone's coming to you saying, gosh, they're closing their right eye all the time, sign of double vision. Or they have a really significant head tilt, probably sign of double vision. So we're looking at those cues as well before we even get into the objective piece.
And the answer to poll question 2 is E, all of the above.
All of the above. Yeah.
You guys run a tough bargain here, I tell you.
All right, moving on.
Okay, now we're going to move into talking a little bit about intervention. So what can you do when you see some of these issues? Just a quick note on the graphic here. This theoretical model was developed by Mary Warren, who's an occupational therapist, to help advocate for better screenings and intervention for people with brain injury with visual issues. And it's a hierarchical model, which means you've got to be paying attention to what's happening at the base of the model. So at the very basic, in rehab, it's important to look at and address ocular motor control, visual fields, and visual acuity, which is why we screen for these things, because if there's impairments in any of those, that's going to negatively impact attention, scanning, pattern recognition, our ability to remember with our eyes, and then overall, like our visual perception, our ability to really think about what's happening and be functional with our vision. So when we think about screening, evaluation, and intervention, we like to start at the base of the pyramid in looking at those things. But when you have identified issues, there are 2 routes you can take. You can take a compensatory, so find a workaround. Let's make you comfortable and help you be a little bit more, we're not gonna necessarily make anything, we're not gonna try to fix your vision, but we're gonna help you do things to help you be comfortable with it so that you can be functional and get around a little bit better so it won't have such a negative effect on your functioning. But then also you can work on getting it better. Our brains can learn. And there's more and more research coming out about neuroplasticity, and vision was a system that was previously thought of as a static system, not amenable to plasticity. But when you really think about it, it's a brain system. It's input, it's processing, and it's output. So of course it can benefit from some remedial intervention, we recommend a combination. The first line of defense is to get a person comfortable. Some patients with brain injury cannot participate in remedial activities because of their attention or behavior, or for whatever reason, or maybe their arousal isn't there yet. So, they're not going to be able to participate in a lot of, drills or exercises to make things better, but we can help them be more comfortable so that they can get better aroused and can pay attention a little bit better and may not have as bad of behaviors because they're a little bit more comfortable with what they're seeing. So we recommend both compensatory and remedial activities. So here are a few compensatory interventions that we think that you could implement in your practice to help people be more comfortable.
Yeah. So what you're not going to see on this page of patch pictures is a black eye patch. And I think black eye patches are still happening out in different hospitals and clinics, less and less as we've been traveling around the country and asking the question, like, who still uses a black eye patch? It's still out there, but we'd like to offer an alternative to the black eye patch, which is a spot patch. And Dr. Pulitzer likes to tell this story that one day he was so frustrated because one of his patients had double vision and he just didn't know what to do and couldn't help her right away, and walked by the nurse's station and there was a roll of transport tape. And so he just ripped a piece off and stuck it on her glasses and her whole world lit up. And it's really fun to hear him tell that story of like how the spot patch came to be one day walking down the hospital hallway. But what a spot patch or a partial patch does is allows preservation of your peripheral vision, or that dorsal pathway that Amy was talking about, that wear. So people have a better understanding of where they are in space still, versus a black eye patch, which takes that away and makes them into a single eye sighted person. So we really like to do the route of a partial eye patch. In acute care and or more early on in inpatient rehab, you'll see more of the entire lens covered with tape. And a lot of times that's just because it takes away any confusion of the patient just trying to look around it as they're becoming more aroused and trying to figure things out. So you'll see one is right in the middle. That is the goal, the least restrictive. This gentleman over on the right, he had an out and downward eye turn. So that's where his patch was placed so that he would have more periphery in his other areas. And the idea is they have double vision. How do we make them comfortable and take one of those images away? And this is a great way of doing that. And it's very cheap and easy. We also use binasal patching. You'll see all the way to the right, Burnell, which is an eye optometric catalog, sells a little guide that you can use. But we use some tape just on the inside, on the nasal side of the glasses, and that can help with double vision. It can also help greatly with visual motion hypersensitivity. When Amy was talking earlier about gaze stabilization and impacting the vestibular system, this has been greatly utilized in our practice of helping to calm some of those oversensitive patients down. So it's been a really nice adjunct to our toolkit. We do have some videos of a gentleman doing some reading before and after using binasal patches. You're not going to hear greatly what he's doing, but I want you to watch the things that are happening while he's reading. Okay, so as he's reading, he's using almost 4 fingers to kind of guide his spatial cues, like where am I looking? How am I keeping track of where my eyes are looking at the page? And then with the binasal patches, And I'm sorry that you can't hear it well on this, but I'll tell you that that was a little choppy and slowed reading. And in this one, he's not using a whole hand to guide his reading. He's more fluid and quick in his reading, less head turning. So it's a much more comfortable experience for him. And I think that's how he described it as well. It's like, oh, I can just sit here and read and this feels more normal. And so that's a lot of the language that we get from people who benefit from binasal patches is, oh, I feel normal again. I can see, you know, how I used to. This calms my system down. And so that's a really nice approach that we've been able to practice. Another compensation that we use for folks who cannot blink their eye to help with protecting the cornea, there are what's called eyelid weights. And these eyelid weights on this picture, if you look down, happen to be skin tone color. We have a set in our clinic that are actually a trial set from a place called Blink Ease, and they're silver, so they're a little bit easier to detect and not lose. But they're placed on the eyelid with double stick tape, and there's different grams of weight in each of the eyelid weights, and so depending on how much assist they actually need is dependent on the size that we put on. The doctor can help with this in clinic, or we have really comfortably trained OTs who feel good about helping their patients right away before they even get into vision clinic so that they can start protecting their eyes. If you don't have lid weights, another thing that we're doing is helping by using lubrication with nursing, taping the eye at night, using moisture chambers at night in conjunction with the lubrication drops that one of the eye doctors might order. So before even getting to an eye doctor, you can tape that eye closed to just help protect it, and then get the doctor on board and get some better medications to help. This is a compensation for photophobia, or the light sensitivity that we were talking about earlier. These are called FL41 tinted lenses. The FL41 is a tint that seems to help calm people down, or calm the system down in those bright lights or noisy environment, like I like to say visually noisy environments, which can be light, extra movement, all kinds of things. You can get them for $12 on the Noir website, and they are actually number 47. So I know that there's been confusion when I first started trying to find them. I went to Noir and I was looking at 41. That's not the same color. It's because the FL41 tint is product number 47. So just a heads up if you go looking for them. 12 bucks, easy fix. Okay. Another compensation that we use in conjunction with the optometrist. So when we go to vision clinic, we've already been spot patching to eliminate the double vision. We've been doing exercise to get their eyes moving, and now their double is close enough together that we need just a little bit more help. The Fresnel prism, when applied to the glasses, helps move the image to where the eye is pointing, so that then the brain can pick up the information and help get them single. So that is a Fresnel prism. It's temporary, it sticks on. We keep several in a case for clinical use, so then we can clean them and use them in between patients. And there's a quick video here of a gentleman. Actually, I'm not even gonna play it because you can't hear it, but I want you to look. When he's reading here, he's got an eye closed, he's slowly reading, and then in this video, he has a Fresnel prism on. Both eyes are able to be open, his face is less tense, and he has more fluidity of reading. And then this is an example of a compensatory prism setup. It's called a Pelly prism, and it's a large amount of prism that brings visual information into the area that is not impacted. So it can be a safety approach, so that when things are coming in their side or background, it alerts them to that. It takes a little cognition, I think, to be super successful, because they have to glance into the prism, but it's also just a compensatory option out there.
Okay, when we talk about remedial interventions, and we're going to slide into home here very quickly, it's important to integrate all the other systems to help reinforce what's happening with the eyes. We take a multisensory approach. Here's a suggested treatment process. We think that all treatment for vision should be bathed in spatial awareness, so be tapping into that dorsal visual pathway. Where am I? So they could answer where is it, and work on the sensory motor aspect of things, but then also working towards automaticity or making it more functional. General guidelines for remedial interventions. For acuity issues, you're always going to go to the optometrist or ophthalmologist for glasses. For eye movement coordination, we have eye movements that we recommend. If double vision is present, you can work on smoothing out eye movements or increasing range of motion one eye at a time. If there is no double vision, you can do the eyes together. For eye alignment, if there is double vision with an eye turn, we recommend a collaborative treatment plan with a vision doctor. And if a person is having having an eye alignment issue but are not having double vision, it's important to not do a ton of exercise, because you can then turn that eye back on, and then they may not be able to re-turn it off if they get double vision that can't be corrected. OT and PT are great to collaborate for gaze stabilization issues. Visual fields, this is where we still take a compensatory approach in terms of the patient has to learn how to move their head and eyes very quickly to compensate for where it's lost. But you can also do eye movement exercises to help those eye movements get quicker and more fluid. Visual inattention is similar to visual field, but you want to do a lot of multisensory input. And then for any vision loss, you have to do compensatory activities. We have a set of exercises that we recommend that came from a research study that we did at Craig. We had 20 participants that did extra therapy every day, and they did standard of care vision type exercises, and then they did the oculomotor C exercises. It was a pilot study, so really it was more for us to check feasibility, but all the patients improved, and the patients did find the more remedial exercises enjoyable and tolerable, and benefited from them. These are the exercises that we recommend. Sensory eye stretches, which we're going to show you really quickly, tracking, Cycads, gaze stabilization, working on visual motor localization, and then convergence. And here's an example of the protocol that we used for our study, and we use on almost all of our patients to help them with their eye movements. But if you could do one exercise, we recommend sensory eye stretches, and this is basically an isometric push-up for your eyeballs. And just here's a picture of a guy doing sensory stretches and having a hard time finding where to look his eye. But in this picture, you have a touch, so you have them feel where to look. You have them push down and look right there, and then you give them auditory feedback. I want you to push really hard, go, 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 go. I think there's another where he's kind of having a hard time finding. But then here's him after doing these for a while. You see we're giving him auditory, tactile input, and then helping him reinforce where to look with his eyes. And this just gives really deep input to the brain and the eye, and helps as a good foundation for coordination. But now we're at poll question number 3.
Launching quick. It's been launched. Well, I thank you both for your time. I know we're coming up on our hour, and I feel like I could listen to you both for the rest of the afternoon. So really appreciate your time. There are some other questions that had come up. What I'd like to do is, just for time purposes, send those to you. And if you could answer those, and then when I follow up with people after the webinar, I can answer their questions from you for them.
We would love to
Definitely.
do that.
Perfect, thank you. And I'm gonna go ahead and close this down in about 4 seconds. All right, I think we're good.
All right. So in summary, vision can be addressed in rehabilitation, especially for eye health, and even just to identify what issues a patient might be dealing with and how it might be impacting their function. But we want to challenge you to think about how to compensatorily make them comfortable, and then how can you start moving them in the right direction in terms of remediating the issue. And we believe very strongly in interprofessional collaboration. We will help with the discussion, and then please stay in touch with Craig for any needs you might have.
And thank you again both so much. Thanks everyone for joining us. As I mentioned earlier, CE credit is being provided by our partners at CEU Institute. So you will be receiving an email directly from them regarding any of your CE credits. So make sure you keep an eye out for that. Sometimes it can linger in your junk folder. So make sure to check that over the next few days. You should be getting that next week from them. And what you'll need to do is fill out their survey and then let them know any of your license information. You'll also receive an email from us with a separate survey if you'd like to participate in that. It always does help us to help with these great topics. But do keep in mind, our survey is not associated with the CEU Institute. But we will also have a recording provided. And if you ever have the need of, we can come to you and do this presentation for you locally. So feel free to reach out to me with that. So thank you very much. Amy, Karen, thank you very, very much. You guys are wonderful. We'll sign off now.